Thank you, Dr. Chan. And it's an absolute honor to be invited to speak here today. Thank you so much for the chance to share what I learned in pediatric sepsis on your absolutely wonderful educational platform. So without further ado, I chose this topic just like Dr. Chan mentioned. He suggested, what about pediatric sepsis, given that the Phoenix criteria is a really landmark study that was published last year, so it was super new. But I thought it would be more applicable to everyone if I would probably focus on the initial resuscitation and instead of just talking about the criteria. So today I'll first talk a little bit about sepsis and why it's so important of a topic in pediatrics. We'll talk about the latest definition, as just mentioned, as well as how to recognize it, and then talk about initial resuscitation, also referred to as a golden hour, as alluded to in my title. And we'll do a bit of a deeper dive into this topic and discuss the evidence with regards to where the current recommendations come from. And finally, I'll share a case we saw last month, which hopefully will help bring home the messages I have to share today on why pediatric sepsis and the importance of capitalizing on the golden hour is so important. So, sepsis and septic shock, they're a major cause of morbidity and mortality in the pediatric population. It kills people. For those of you listening today who are clinicians, I'm sure you've probably seen sepsis-related case fatalities before. And in bad cases, sometimes survivors are left with significant morbidity despite the team's best efforts. And that's why it's extremely important. If we look at these figures, so neonates and kids less than 19 years of age account for half of the 50 million global sepsis cases per year. That amounts to 25 million. And they also account for a third of all sepsis-related deaths. Case fatality rates are quoted to be as high as 5% in kids who are previously healthy, and a whopping 50% for kids and children with comorbid medical conditions or hospital-acquired infection. And this can be up to as high as 3 million deaths yearly. Sepsis is also familiar to us who do pediatric intensive care, accounting for around 8% of all PICU admissions. And finally, of those who do survive, a third of these kids develop new or worsening functional impairment, which can significantly impact their quality of life. This epidemiology data was taken from a massive meta-analysis done in 2017 and published in The Lancet. So this included data from nearly 200 countries and territories. On the left, you can see a nice visual representation of the disparity in distribution of global sepsis incidence and mortality. You can see that kids less than 5 years of age are disproportionately affected compared to older kids, with around 20 million incident cases, versus only 5 million cases in older kids and adolescents. The majority of deaths also occur in the younger age group. On the right here, you can see the most common causative pathogens implicated in sepsis. So HIC refers to higher income countries, which is pretty much in line with the type of sepsis we see in Hong Kong. They're mostly all bacterial, with influenza being the exception. In lower and middle income countries, in addition to similar bacterial pathogens, they also see sepsis from exotic pathogens that we're not familiar with, such as those causing malaria, dengue, and typhus. This infographic illustrates the impact of pediatric sepsis on society. Because kids are at a age of rapid development, sepsis can either transiently or permanently affect their ability to reach their full developmental potential due to mortality and morbidity across multiple core outcomes, such as cognitive, emotional, physical, as well as social domains. And these can have very significant both indirect and intergenerational costs for society. Extensive evidence demonstrates better patient outcomes if sepsis and septic shock are recognized and treated early, so thus giving rise to the name golden hour. Treatments administered within the first hour of recognition have the potential to significantly alter a patient's outcome. And I'll talk more in depth about this during our discussion on initial resuscitation. So, moving on to the definition of sepsis. Last year, as mentioned, an extremely important landmark paper in pediatric sepsis was published, and some of you may have already heard of it. It's the Phoenix sepsis criteria for pediatric sepsis and septic shock. But before going into the new criteria in detail, it helps to understand what came before it. So prior to this new criteria, we were using the IPSCC criteria from 2005. These criteria characterize sepsis as suspected or confirmed infection in the presence of the systemic inflammatory response syndrome, also known as SIRS. There was also a set of definitions for shock and severe sepsis, which signifies sepsis with multi-organ dysfunction. And this SIRS-based definition actually extends way back before 2005 to 1992. However, since publication, many issues were identified. So, first of all, these definitions were based on expert consensus, not on data. Essentially, a bunch of white males from the US sat down and wrote them. So, very narrow scope and not representative. Secondly, the SIRS criteria is very non-specific. A lot of kids meet SIRS criteria who don't actually have a severe infection. If you look at all the PED patients attending the A&E, you'll find that probably up to half or more would potentially fit the criteria, such as a febrile bronchiolitis infant, for example, who comes in and has tachycardia and tachypnea, but who actually just has a respiratory viral infection. So they might be ill and need clinical care, but we wouldn't consider these kids as being septic, because when they're septic, we're referring to the kid who we're worried might die of a severe infection, right? So because of this oversensitivity, the IPSCC criteria were unable to reliably identify kids with infection who are at the greatest risk of poor outcomes. In 2016, Sepsis 3 for adults was published, and it reconceptualized sepsis as a life-threatening acute organ dysfunction secondary to a dysregulated host response to infection, as you can see here. So this finally departed from the SIRS-based definition, and it took 35 years. This time, it was also developed via data rather than on expert consensus. However, the authors stated explicitly that these criteria were not developed with pediatric data and had not been validated in kids, so it continued to leave pediatric practitioners hanging. However, the worldwide paradigm-wise, the pediatric community also began to shift towards this definition, despite at the time it applying only to adults. So recognizing this gap, the Society of Critical Care Medicine commissioned a task force to update the pediatric definitions, and following extensive groundwork and research, which I won't go into lots of detail in today in the interest of time, but finally the new definitions were born. So the new paradigm of sepsis is that of a life-threatening organ dysfunction in context of suspected infection became the basis for a retrospective multi-center international cohort study used to develop the new criteria. And the primary outcome was set as in-hospital mortality because of its life-threatening nature, as you can see here. And organ dysfunction was evaluated by identifying best-performing organ dysfunction subcomponents. And finally, infection in this setting was defined as suspected infection within the first 24 hours of presentation. And kids either received systemic antibiotics or underwent microbiological testing to fulfill this definition. So a whopping 3.6 million hospital encounters across 10 study sites from across the world were evaluated to derive the new definitions. And how did they do this? So essentially, they broke apart a complete set of existing organ dysfunction scores, like the IPSCC we just talked about, the PALOD, Podium, P-SOFA, etc., and identified which ones worked best for each organ system in predicting mortality in both infected as well as non-infected patients. And there were 8 individual organ systems that were represented. So apart from cardiovascular, respiratory, coagulation, and neurologic that you can see in the diagram here, there are also endocrine, hepatic, immunologic, and kidneys represented. The best performing ones were identified for each system, then put back together into machine learning models, and stacked regression was used to create a composite model to predict mortality. In the end, they came up with 2 equivalently performing models. So one of them had 4 systems and one of them had 8. So given equivalent performance, in the interest of pragmatism, the 4-system model was chosen. And all of that fancy math was then reduced into an integer-based score to facilitate implementation in clinical practice. And thus, the Phoenix sepsis criteria was born. So this is the final model. Basically a stratification of different levels of organ dysfunction across the 4 organ systems. And according to several mostly objective and indubitable variables that are easy to apply. So if we take a look at the respiratory system, respiratory system here. It employs PF ratios if an arterial line is present, and if not, then SpO2, FO2 ratios can suffice. So if you imagine, 1 point would be the kid who's maybe just on a bit of oxygen, 2 points to the kid who's maybe a little desaturated on non-invasive, or like gets intubated but does really well after you intubate them. And then 3 points would be the kid who gets really, really hypoxemic. You're having to go up on pressures and needing a lot more FO2. So for cardiovascular, you can score a total of 6 points based on 2 subcategories. The first subcategory is based on the use of vasoactives or lactate levels, whereas the second is blood pressure based. For coagulation, it's really straightforward. You measure platelets and clotting, fibrinogen, and then calculate. And finally, for neurological, one only has to calculate GCS and check pupils to determine eligibility. So finally, sepsis identified if by a score of 2 points or more in kids with suspected infection, and septic shock is identified as the kids who fit the criteria for sepsis and also have at least 1 cardiovascular point. So the results of the validation study for the score show that overall, kids with suspected infection in the first 24 hours of presentation had a total in-hospital mortality of less than 1% in higher resource settings and 3.6% in lower resource settings. However, if they fulfill the Phoenix sepsis score of 2 or more, they are at a higher risk of death with an in-hospital mortality of 7% in higher resource settings and nearly 30% in lower resource settings. So this is more than 8 times that of kids with suspected infection who didn't meet these criteria. And finally, kids who were more ill and meeting Phoenix criteria for shock had 11% and 34% mortality, respectively, in higher and lower resource settings. So these figures show that the new criteria demonstrated a higher positive predictive value as well as comparable or higher sensitivity to the old IPSCC criteria when using the old categorizations of sepsis, severe sepsis, and septic shock. This was proven for both composites of death and well as early death within 72 hours or the use of ECMO. So what does this all mean? Essentially, the new criteria shift the focus to the underlying pathophysiology of sepsis and removes SIRS from the definition and brings the pediatric definitions in line with adult sepsis 3 by redefining sepsis as a life-threatening organ dysfunction in the setting of infection. However, it's very important to remember that these criteria are designed and validated to predict mortality in kids with suspected infection already. They are not a sepsis screening tool, and they're not able to predict which kids are at risk of developing sepsis. So if that's the case, how can we make use of these new definitions? So first off, we can say goodbye to the SIRS definition of sepsis, and we can remember Phoenix whenever we encounter a patient with suspected infection and consider whether they would fit criteria. And you don't even need to whip out the table and manually calculate. You can just input it into MD-Calc online, which is super convenient. So if I see someone ticking the boxes for sepsis according to the Phoenix score, that means they're at a risk of life-threatening organ dysfunction, right? So it would be prudent to consult PICU for close monitoring or possible need for organ support. Also, please note that the Phoenix score was designed for all children except for those still within their birth hospitalization or for premature babies. So we can't use it in that setting. Okay, so I've talked about why pediatric sepsis is so important in the latest definition. Let's move on to how to recognize sepsis. So recognition is extremely important, right? Because before we enact our golden hour bundle, we have to diagnose it first. However, early recognition of a kid with sepsis who presents among hundreds of febrile children is inherently extremely challenging. It's known as the great mimicker. You can have a very non-specific clinical presentation. In our kids, sepsis presentation also varies greatly with age. For example, in a neonate or an infant, they would commonly present with feeding difficulties or apneas, which is very different, of course, from a kid or an adolescent who would present more similarly to an adult. Age-related variation in vital signs can also complicate matters greatly, especially when providers are lacking in pediatric experience. And in Hong Kong, we don't have pediatric emergency physicians, right? There's no pediatric EDs. So we have to rely on the judgment of adult emergency physicians to triage our kids, provide initial management, and reach out to pediatricians early if appropriate and if that support is available. So what can we do to mitigate these barriers in the failure of recognition? So first of all, we have to understand why there might be a failure, and I've talked a bit about it already. But it actually all comes down to inadequate sepsis education awareness. And very importantly, these challenges of early recognition is not only amongst health professionals though. It's aggravated by policymakers, health administrators, researchers, and also the general population. So, for example, of course we would never blame the caregiver. However, delayed recognition is a real thing, right? So delayed recognition, for example, by a caregiver would contribute to a delay in seeking care, resulting in late presentation to hospital and inferior outcomes. So it's down to policymakers and health administrators to educate the general population to try and prevent late recognition. However, if we focus, though, on what we can do in our domain as being a health professional, it's worth discussing what we can do to detect sepsis early. So this revolves around coming up with good sepsis screening tools. So the ideal sepsis screening tool would be sensitive, so sense enough to recognize the condition early, but specific enough to minimize the waste of resources and avoid harming patients with inappropriate treatment. It should be really easy to use and have minimal inter-rater variability, and also easily be incorporated into clinical workflow for use. Ideally as well, it would be broad, so it can encompass as many kids as possible who are at risk for sepsis and should allow for prompt attention to the patient and early treatment without increasing unnecessary use of broad-spectrum antibiotics and preventable hospitalizations. So it's important to remark too that empirical sepsis treatment bundles are geared towards a bacterial cause because bacteria are implicated in around 80% of pediatric septic shock. Yet the other 20% encompass non-bacterial pathogens like viruses like the flu, so which can also, of course, lead to temperature alterations, shock, and organ failure. So in these cases, sepsis bundles could lead to unnecessary antibiotic use. And that's why specificity is important. Finally, also very importantly, it should be tailor-made to institutions in order to be effective and sustainable. So because of the importance of early recognition and timely treatment within the golden hour, the past few decades have led to an emphasis on the systematic implementation of screening protocols. Systematic screening has been shown to improve outcomes. It results in fewer sepsis, missed sepsis diagnoses, a reduction in time to treatment, and which obviously has knock-on effects, which translate to shorter length of stay as well as improved morbidity and mortality. I'd like to highlight this example of systematic screening of kids for sepsis in the USA. So though it's been on the radar for decades, it only gained traction as a policy priority around 10 years ago after a really tragic case in New York. So Rory Staunton was a 12-year-old boy who died of group A strep septic shock in 2012. He sustained a scrape on his arm during a basketball game at school, and he wasn't sent to the nurse to address his wounds. After falling ill the next day, his parents recognized he was sick and brought him to his pediatrician, who also recognized that he might be unwell and sent him to an ED for rehydration. However, at the ED, hospital staff missed several symptoms indicating he could be developing sepsis, and he was sent home. His condition continued to worsen, and by the time he returned to hospital the next evening, he was already seriously ill, and by then it was too late, and he died of sepsis. After his death, his family launched an advocacy campaign to increase awareness of sepsis and improve sepsis recognition and treatment in pediatric care so that his death wasn't in vain. And this gained national publicity and finally culminated in the 2013 passage by the New York State Legislature of what are now known as Rory's regulations. So the regulations mandated all New York hospitals to implement evidence-based protocols to facilitate early recognition of sepsis through screening tools and implement a sepsis care bundle covering the golden hour. So consisting of fluid resusc, intravenous antibiotics, and a blood culture sample. In 2017, the American College of Critical Care Medicine also incorporated a recommendation of routine pediatric sepsis screening as part of its clinical practice parameters for hemodynamic support of pediatric and neonatal septic shock. This is still the most updated guideline as of today. And specifically, in the top right here, you'll see that it recommends that each institution implement sepsis care bundles for kids that include a recognition bundle containing a trigger tool for rapid identification of patients with suspected septic shock at that institution, as well as a resuscitation bundle for any patients who are identified by the trigger. And 3 years later, in 2020, this was also followed by the recommendation of the Surviving Sepsis campaign that hospitals have to implement systematic screening for timely recognition of septic shock and other sepsis-associated organ dysfunction in acutely unwell kids. So here's an example of a commonly used sepsis screening tool worldwide, and it comes from the Pediatric Septic Shock Collaborative. It relies on abnormal vital signs and physical exam findings, as well as the presence of medical conditions that may confer an increased risk of sepsis, and in doing so, aim to identify patients prior to the onset of sepsis or septic shock. And the sensitivity is quoted to reach 99% for this, though the positive predictive value is only 20%. These are some more examples of other screening tools published in the literature. So some of them utilize a framework for defining sepsis, such as the IPSC SIRS criteria at the time. Depending on healthcare infrastructure, some are pen and paper based, whereas others are embedded into the electronic healthcare system. However, as you can see, it's impossible for there to be a single perfect screening tool because efficacy would vary greatly depending on the location. So whether it's utilized in the ED, whether it's for inpatients or in the PICU. Thus, individualized screening tools tailored to local institutions and where the patient is very important. And finally, population screening could also vary depending on how broad or narrow the target population is set to be. So more targeted approaches would have the advantage of fewer false positives because sicker patient groups would have a higher sepsis prevalence, but this would be at the risk of missing sepsis cases in patients in whom the provider has not already identified a higher severity of illness. Anyway, so let's look at the evidence behind whether these screening tools did their job. So following the passage of Rory's regulations was the prompt completion of a golden hour bundle associates with lower mortality. 5 years after the mandate was passed, this retrospective cohort, drawn from 54 hospitals in New York State, encompassing over 1,000 kids, showed that completion of a sepsis bundle within 1 hour was associated with lower mortality, as well as shorter hospital length of stay. And this is illustrated nicely in this forest plot on the right. But one thing I found interesting about this study is that protocol compliance was actually really poor. Only 25% reported completion of the 1 hour bundle within 1 hour. So clearly that needs some serious work, and it's an ongoing challenge whenever new things are implemented. At the Prince of Wales Hospital, we utilize a pediatric early warning score system in our general pediatric wards called PEWS for short. So to those of you who aren't familiar with PEWS, it works to identify pediatric patients who are at risk of deterioration based on bedside clinical assessment and allows for mitigation and then subsequent escalation of care if mitigation is unsuccessful. It's efficacious in general deterioration and it's not only sepsis specific. A retrospective study in 2021 in the UK evaluating PEWS score's ability to predict PICU admission in febrile children in the ED looked at over 11,000 febrile ED attendances over 6 NHS hospitals, and it found that the PEWS score had excellent discrimination for PICU admissions, as well as sepsis-related mortality, and moderate discrimination for hospital length of stay. So I'd like to come toward the end of this section on sepsis recognition by once again bringing the focus back to the importance of education and awareness in sepsis. I think this study highlights it really well. So in 2016, a prospective quality improvement study was performed at the ED at the Royal Children's Hospital in Melbourne. So it targeted improvement in ED sepsis management because they had a series of sentinel events, including recurrent episodes of delayed antibiotic administration. And they decided to perform a prospective cohort study to determine whether these quality gaps were just isolated events or part of a more systematic problem. So what they did is they emphasized education with regular sepsis workshops, presentations, and simulation training. And they also emphasized awareness by establishing a sepsis lanyard that was distributed to all ED staff. They put up posters and printed guidelines in common areas like the tea room, and they also held multidisciplinary progress presentations with staff. And the result was really dramatic. So if you look at the figures on the diagrams, pre and post intervention, there was a significant reduction in time to IV antibiotics, which is cut in half from 2 hours to 1 hour. And time to establishment of IV access, administration of IV fluids, and ordering of blood gas was also significantly reduced. Hospital length of stay was also reduced by around half a day. So it really helped bring home the point that education and awareness is really important and can also help improve outcomes. So to sum up this section, I hope that these key takeaways were driven home. Systematic screening saves lives. It's really important that screening tools are in place, that sepsis can be picked up early and treatment can be initiated rapidly to reduce mortality. And these screening programs are usually part of sepsis bundles or QI programs. And they would only be successful, though, with ongoing sepsis education. And this means across society and not just within healthcare. If a family member is able to recognize their child might be septic and bring them in early, that totally improves their chances of survival. And finally, for all this to be sustainable, remember it has to be done in a fashion which is adapted to local patients, their resources, and the processes within each institution.